Communication and physical assessment of the child and family. We're going to start with using an interpreter. Nursing guidelines. 712. This has been seen on NCLEX. Make sure you know it. Look what it says. Communicate directly with family members when asking questions to reinforce interest in them and to observe non-verbal expressions, but do not ignore the interpreter. So when you have an official interpreter, that's what you're supposed to use. You can't use a coworker or a family member. You have to use an official interpreter. You have to, when you're asking the questions, do not look at the interpreter, look at the patient, because while you're asking the question, you're waiting for the interpreter to interpret what you're saying. You're looking at body gestures and you're looking at nonverbal communication, because remember, nonverbal communication tells you a whole lot more than verbal communication does, okay? So that's important. Make sure that you're looking at the patients and you're directing your question to the patient, even though you have an interpreter there. Refrain from interrupting family members and the interpreter while they're conversing. Avoid commenting to the interpreter about family members because they may understand some English. Allow time after the interview for the interpreter to share something that he or she thought could not be said earlier. Ask about the interpreter's impression of nonverbal cues to communicate and family members' reliability or ease in revealing information. Arrange for the family to speak with the same interpreter on subsequent visits whenever possible. That helps with the rapport. All right, blocks to communication. These are things you want to avoid, you don't want to do. So for the nurse, avoid socializing, giving advice. You're never judgmental and you never give advice to nursing. Defending a situation or an opinion. Using stereotypes or cliches. Using complex medical language or medical jargon. Limiting expression of emotion by asking directed, closed-ended questions. And on the side here, remember, we always want to ask open-ended questions, except in 3 situations. These situations, you're going to be asking closed-ended questions. You want a yes or no. And those situations, guys, are suicide. You ask them directly. Are you having thoughts of harming yourself or someone else? Abuse. If you suspect abuse, you ask them directly. Is that person harming you or is somebody hurting you? And the third one was my third one, health history. If you need a quick history, like that patient's going to surgery, you need information right away, you're going to ask them closed-ended questions. Do you have any allergies? Have you drank any alcohol within the last 24 to 48 hours, etc., right? But other than those 3, normally you want to ask open-ended questions to facilitate communication. Avoid interrupting and finishing the person's sentence. Now, here are signs of information overload for the patient. You're giving them way too much information, they can't handle it. Constant fidgeting or attempting to move away from you. Them looking around. Them frequently looking at the watch or clock. Attempting to change the topic of discussion. This last one has been seen on NCLEX before, and it's usually in regards to like, give me a second. It's usually in regards to a woman that just had a mastectomy. And you're coming in to do teaching, and you're teaching her about wound care, but she completely changes the topic. You think she's ready for that teaching? No, she's not coping well. So what are you going to do? Therapeutic communication. Make an observation. I noticed I started talking to you about X and you started talking about A. And don't say anything after that, because remember, silence is a form of therapeutic communication as well. And then let them speak, okay? All right. Communicating with children, guidelines. Avoid sudden or rapid advances. They don't know you and they're scared of you. Communicate through transition objects such as dolls, puppets, stuffed animals before questioning a young child directly. Assume a position that is eye level with the child. If you don't do that, you are a big giant towering over them and they will be scared. You want to get down to eye level with them. Speak in a quiet, unhurried, and confident voice. Speak clearly. Offer a choice only when one exists. Be honest. Allow children to express their concerns and fears. Early childhood. Children younger than 5 years old are egocentric. They see things only in relation to themselves and from their point of view. Therefore, focus communication on them. Tell them what they can do or how they will feel. Experiences of others are of no interest to them. It is futile to use another child's experience in an attempt to gain the cooperation of small children. They don't care. They can't even place themselves in someone else's shoe. School age years. The children in school age years, they want explanations and they want reasons for everything, but they don't require verification. They just want to know why, but they're not going to double check what you said. I mean, you want to be honest, but still, they want a reason. And I thought this was cute. With the school age child, you have to be careful with your wording because they take things literally. So if you're going to be given injection, you can't say, oh, you're just going to get a small stick in the arm, because they're going to imagine a stick poking out of their arm. Remember, the school age child is very preoccupied with their body integrity. School age children have a heightened concern about body integrity. Remember, the school age child, they're the ones you always have to have bandages. $726. Performing a pediatric physical examination. Everyone there? All right. You want to perform the examination in an appropriate, non-threatening area. Make sure the room's well lit. Have some toys and games available for the child. Provide privacy, especially for school-age children and adolescents. Observe behaviors that signal the child's readiness to cooperation, such as talking to the nurse, making eye contact, allowing physical touching. If signs of readiness are not observed, use the following techniques. Talk to the parent while essentially ignoring the child. Gradually focus on the child or a favorite object, such as a doll. If the child refuses to cooperate, use the following techniques. Try to involve child and parent in the process. Perform examination as quickly as possible, going from least invasive to most invasive. Use a quiet, calm, confident voice. Begin the examination in a non-threatening manner for young children or children who are fearful. If several children in the family will be examined, begin with the most cooperative child to model desired behavior. So they can see, you're not doing anything wrong, you're not harming them. Provide choices such as sitting on a table or in the parent's lap. I put a star next to it, make sure you know it. Allow the child to handle or hold equipment. I don't know why I don't have a star next to that. That's a famous test question as well. Encourage the child to use equipment on a doll, family member, or examiner. Examine child in a comfortable and secure position, usually sitting on the parent's lap. Proceed to examine the body in an organized sequence, usually head to toe, with the following exceptions. Alter sequence to accommodate the needs of children of different ages. You're going to examine the painful area last, And in an emergency, examine vital functions such as ABCs and the injured areas first, obviously. Reassure the child throughout the examination, especially about bodily concerns that arise during puberty. Praise the child for cooperation during the examination and give a reward such as a small toy or sticker. Nursing alert. The body mass index for sex and age may be used to identify children, adolescents who are either underweight. Underweight is less than the 5th percentile. Healthy weight, remember healthy is between the 5th and 85th percentile. Overweight is 85th to 95th percentile, or obese, higher than 95th percentile. Make sure you know them. Nursing alert. Do not add a degree to the finding obtained by taking temperature by axillary route. So let me try to begin. It says the belief that oral temperature can be estimated by adding 1 degree Celsius to the temperature taken in the axilla is incorrect. And that used to be a school of thought. Axillary temperature is lower than oral temperature, but the difference varies too widely for a standard conversion. So do not add a degree to the finding obtained by taking the temperature by the axillary route. When taking blood pressure, use an appropriately cuffed size. When the correct size is not available, use an oversized cuff rather than an undersized one, or use another size that more appropriately fits the cuff size. Do not choose a cuff based on the name of the cuff, such as an infant cuff, because sometimes you have really big infants or smaller ones. Compare blood pressure in the upper and lower extremities to detect abnormalities such as coarction of the aorta, in which the lower extremity pressure is less than the upper extremity pressure. Make sure you know the differences in color changes of racial groups. Cyanosis, that's a bluish tone through the skin, reflects reduced hemoglobin. Pallor, paleness, can be a sign of anemia, chronic disease. Erythema, that's the redness. Ecchymosis, large diffuse areas, usually black and blue. Petechiae, same as ecchymosis, except for size. Small, distinct pinpoint hemorrhages, and jaundice. Yellowing staining of the skin, usually caused by bile pigments. Now, I put a star next to the cyanosis and jaundice because when it comes to test questions about discoloration of racial groups, those are the usually the two that they'll ask about the most. So I'm not telling you don't know the others, just make sure you know these first. When it comes to cyanosis, that bluish color. And people with more lighter skin, they'll have a bluish tinge, especially in palpable conjunctiva, such as the lower eyelid, nail beds, earlobes, lips, or mucous membranes, soles, and palms. But in darker skinned people, we'll see ashen gray lips and tongue. Now go down to jaundice. If you're looking for jaundice, remember that's the yellowing staining of the skin, usually caused by pigments. In lighter skinned people, you'll see yellow staining, which is, you'll see it in the sclera of the eyes, the skin, fingernails, soles, palms, and oral mucosa. But in darker skinned individuals, most reliably assessed in the sclera, hard palate, palms, and soles. You guys learned about that in fundamentals of nursing. You're seeing it again. Various patterns of respiration. You guys are over here crying. A lot of this, so much review. Tachypnea, increased rate, increased breathing. Bradypnea, decreased rate. Dyspnea, distress during breathing. Apnea, cessation of breathing. Kussmaul's respiration, that's hyperventilation, gasping, and labored respiration, usually seen in diabetic coma or other states of respiratory acidosis. Cheyne-Stokes respirations, gradually increasing rate and depth with periods of apnea. And the seesaw or paradoxic respirations, the chest falls on inspiration and rises on expiration. And you should really be seeing the opposite. That's why it's paradoxic. You should be seeing the opposite. When the person takes a deep breath, we should see the chest rise. And when they breathe out, we should see it go back down, not this opposite that we're seeing here. Capillary refill should be brisk, 2 seconds or less. Prolonged refill of 3 seconds or more is an important warning sign. To distinguish, your S1 and S2, your lub-dub, guys. To distinguish between S1 and S2 heart sounds, simultaneously palpate the carotid pulse with the index and middle fingers and listen to the heart sounds. S1 is synchronous with the carotid pulse, and that's how you tell the difference between your lub-dub. S1, which is your lub, S2 is your dub. A tense, board-like abdomen is a serious sign of paralytic ileus and intestinal obstruction. Absence of femoral pulses is a significant sign of coarction of the aorta, and it's referred for evaluation. That child's going to be referred to a cardiologist. And this is just a review, guys, but make sure you know your cranial nerves. You can't escape them. You cannot escape those cranial nerves. You're going to see it again when you get the psych again, but make sure you know your 12 cranial nerves. And that is communication and physical assessment of the child and family.